Welcome back to the deep dive. Today, we're shifting gears a bit. We're moving away from the chronic stuff and diving deep into the really urgent cardiovascular emergencies, the kind where things go wrong suddenly, catastrophically. We've got a stack of sources here focusing on those life-threatening failures.
That's exactly right. And our mission today is very specific. We're not just reviewing diseases. We're pulling out the critical decision points from these high-stakes scenarios.
hmm
Ruptured vessels, electrical chaos. The goal is to help you spot those immediate red flags,
Yeah.
the ones that mean you have to act now.
Yeah, distilling the need to know for immediate action. We've basically split this into three, let's call them high-pressure zones. First up, aortic catastrophes. Think structural time bombs. Then we'll jump into the electrical emergencies, the heart's wiring going haywire.
Right.
And finally, we'll cover circulation shutdown, basically when blood flow just stops.
And the clock is ticking on viability.
Okay, let's kick things off with those structural failures. Starting with the abdominal aortic aneurysm, AAA, the classic ticking clock. These are often silent killers, right? Found by accident on an ultrasound for, like, gallstones or something.
Totally incidental sometimes.
But here's what jumped out from the sources. Yeah, the size thresholds matter for elective repair. 5.5 centimeter for men, 5.0 for women.
And rapid growth, too, that 1 centimeter per year mark.
Right, that too. But the real push needs to be on prevention before it gets that big.
Precisely. We talk a lot about surgery, but the sources really hammer home that smoking cessation. That's the single most effective thing someone can do to slow down AAA progression.
It's kind of wild, isn't it? A lifestyle change being more powerful than drugs here.
It really underscores how badly smoking damages the actual structure of the vessel wall.
Okay, but let's talk about the absolute crisis, the rupture.
Right.
When that wall finally gives way, what did that presentation look like? Because it's not subtle.
No, rupture is. It's immediate. It's devastating. The absolute key is sudden, severe, acute pain, often described as tearing, usually hits the abdomen, the flank, or the back. And then, almost immediately, hypotension, shock.
Oh.
The numbers are just grim, untreated. Mortality is quoted upwards of 90%.
So that triad, sudden intense pain, blood pressure plummeting, maybe a known history of AAA. You're already behind the eight ball.
Way behind. And sometimes, though not always, you might see those external clues of massive internal bleeding, that bruising on the flank, Gray-Turner sign, or around the belly button, Cullen's sign.
Signs the blood's pouring out into the retroperitoneum.
Exactly. It means massive hemorrhage. That patient needs an OR, like yesterday.
Okay, sticking with the aorta, but shifting from a bulge bursting to the wall itself tearing. Aortic dissection. What's the basic failure mechanism here? Why is it so immediately dangerous?
So think of the aorta wall in layers, right? And dissection is a tear in the inner layer, the intima. Blood, usually under high pressure from hypertension.
The main culprit.
Yeah, uncontrolled hypertension. It forces its way into the middle layer, the media, and rips it apart, creating this false channel, false lumen. And the danger is twofold. That false channel can rupture outwards, or it can block off major arteries coming off the aorta. Think stroke, limb ischemia, kidney failure.
So figuring out where that tear starts is everything for triage. How do the symptoms help us pinpoint the location?
The pain is key again. Sudden, severe, often tearing or ripping. But where the pain is worst gives you a huge clue. If it's mainly anterior chest pain, think Stanford type A. That means the ascending aorta, the part coming right off the heart, is involved.
Okay.
If the pain is predominantly in the back, classically described as between the shoulder blades, that points towards a Stanford type B. The descending aorta is involved after the arch.
And that distinction, A versus B, it completely changes the management plan, doesn't it? That's critical.
Absolutely paramount. Type A involving the ascending aorta, that is a surgical emergency, period. It's too close to the heart. The risk of catastrophic complications like cardiac tamponade, where blood fills the sac around the heart, or the aortic valve just blowing out, it's immediate. Needs repair now.
But type B is different if it's uncomplicated.
Right. An uncomplicated type B, meaning no signs of organ damage or impending rupture, is typically managed medically first. The focus there is strict, aggressive blood pressure and heart rate control. Usually IV beta blockers. You want to reduce the shear stress on that damaged aortic wall, keep things calm, keep the pressure down.
Okay, that makes sense. We've hit the big structural failures. Let's move into segment 2, the electrical emergency room. This is all about the heart's wiring going haywire, leading to stroke or even sudden cardiac death. Let's start with the most common one we see, atrial fibrillation, AFib.
Yeah, AFib. Basically, chaotic electrical activity in the atria. On the ECG, it's that classic irregular rhythm, no clear P waves. The usual risk factors are there: age, high blood pressure, obesity, sleep apnea. But there's a specific danger linked to the rate that often gets missed.
Ah, you're talking about tachycardia-induced cardiomyopathy, right?
Yeah.
Tell us about that.
Exactly. If the ventricles are driven too fast for too long, say, the heart rate's stuck at 150, 160 beats per minute for weeks or months. The heart muscle itself can weaken. It gets exhausted, basically, and starts to fail. But the really hopeful part, this specific type of cardiomyopathy, this heart muscle weakness, is often completely reversible if you can get the heart rate or rhythm back under control. It's a chance to get that function back.
That's huge. And speaking of getting things under control, what's that one absolutely essential blood test you need to check in anyone presenting with new onset AFib? The one that could point to a non-cardiac cause.
Always check a TSH. Hyperthyroidism is a really important and treatable cause of AFib.
Right.
And you also got to ask about triggers, like binge drinking, the whole holiday heart syndrome thing.
Good point. And for managing the AFib itself, the big decision point is anticoagulation for stroke prevention, isn't it?
It is. That's driven by the CAES Eurovasc score. You calculate the score, and generally anticoagulation is recommended for men scoring 2 or more and women scoring 3 or more. And importantly, the stroke risk is pretty much the same whether the AFib is paroxysmal, coming and going, or persistent. The need for anticoagulation doesn't change based on that.
Okay. Now, from the common to the, well, frankly, terrifying electrical shortcut. Wolff-Parkinson-White syndrome? WPW?
Yeah, WPW it's different. You've got this extra electrical pathway and accessory pathway connecting the atria and ventricles. It completely bypasses the AV node, the heart's natural gatekeeper. This pathway is fast and unregulated. Now, the extreme danger happens when someone with WPW develops AFib.
Okay, why is that combination so bad?
Because that chaotic, rapid atrial activity in AFib doesn't get filtered by the AV node. Instead, it can conduct insanely fast down that accessory pathway, hitting the ventricles at rates of like 250, 300 beats per minute or more. And that can degenerate directly into ventricular fibrillation, VFib, which is sudden cardiac death.
That sounds like an absolute nightmare scenario. So
Yeah.
if you have a patient roll in with AFib, and you know or suspect they have WPW, what is the one critical thing you absolutely must not do? The source has really highlighted this pitfall.
This is non-negotiable. You must avoid all standard AV nodal blocking drugs. That means no adenosine, no beta blockers, no calcium channel blockers like verapamil or diltiazem, and no digoxin.
Why? What happens if you give those?
Because those drugs slow down or block the normal AV node pathway. If you do that in someone with WPW and AFib, you essentially force all that rapid, chaotic electrical traffic down the dangerous accessory pathway. You actually make the ventricular rate faster and increase the risk of VFib. It's a direct contraindication. It can kill the patient.
Wow. So what do you use?
You need drugs that slow conduction in the accessory pathway itself or convert the rhythm. Things like procainamide or ebutylide are the treatments of choice in that specific scenario.
That is such a critical distinction. Easy to forget in the heat of the moment when you just see a fast heart rate. Okay, so rounding out this electrical section, when does instability force your hand towards electricity? When do you shock?
Right. If any rapid heart rhythm tachycardias like SVT, AFib with a rapid response, VTach with a pulse causes the patient to become unstable, meaning they have signs of shock like hypotension, altered mental status, acute heart failure, or ongoing ischemic chest pain.
Then you don't wait.
You don't wait. The immediate treatment is synchronized electrical cardioversion. You're hitting the reset button.
And for the opposite problem, unstable bradycardia, heart rate too slow.
If they're unstable from being too slow, first line is IV atropine. If that doesn't work or isn't appropriate, then you need to move quickly to transcutaneous pacing or starting an infusion of an inotrope like dopamine or epinephrine to speed the heart up.
Got it. Clear action pathways. Okay, let's move to our final segment, circulation shutdown, acute limb ischemia, ALI. Outside of the chest, this has got to be one of the most time-sensitive vascular emergencies, right? What causes the blood flow to suddenly stop in a limb, and how do we spot it fast?
Yeah, ALI is critical. It's a sudden cutoff of blood supply. Usually it's one of two things. Either embolism, meaning a clot traveled from somewhere else, most often the heart.
Like from AFib or a clot in the ventricle after a heart attack?
Exactly. That accounts for maybe 60%. Or it's thrombosis, meaning a clot formed right there, usually on top of pre-existing peripheral artery disease. That's about 30%. And you spot it with the classic 6PS. It's a good mnemonic. Pain, severe sudden onset. Pallor, the limb looks white. Pulselessness, no pulse downstream. Paresthesia, numbness, tingling, paralysis, can't move a limb, and poikilothermia, it feels cold.
And I remember the sources emphasizing that paralysis isn't just another P, it's a really bad sign.
It's a terrible sign. Paralysis, along with anesthesia, loss of sensation, means the nerve and muscle damage is already severe. It indicates an immediate threat to the limb's survival. The window for salvage is closing fast.
So what's the absolute first step if you suspect ALI?
Before anything else, even definitive imaging sometimes, get IV heparin on board immediately. Full dose. You have to stop that clot from getting bigger or propagating further down. Then you quickly classify the limb based on those signs and symptoms, and that determines whether the next step is emergency surgery for revascularization or maybe catheter-directed thrombolysis, clot-busting drugs, but heparin first.
Okay, and let's just quickly connect that embolism risk back to the heart. You mentioned clots after a heart attack.
Yeah, specifically after a large anterior wall heart attack, the ones usually caused by blocking the LAD artery, the widowmaker. The front wall of the left ventricle can be stunned or damaged, and a clot, a mural thrombus, can form on that damaged inner surface.
And that can break off and travel?
Exactly. Causing a stroke if it goes to the brain, or ALI if it goes down to a leg. That's why getting an echocardiogram after an anterior MI is so important to look for that potential clot source.
Makes sense.
Oh.
Okay, last major topic. Extremity vascular trauma. A direct injury threatening blood vessels. The key distinction here seems to be sorting out hard signs versus soft signs of injury.
That's the crucial initial sort, because hard signs mean the operating room is the next stop, usually without pausing for extensive imaging. These are the obvious, undeniable signs of a major vascular injury: active, pulsatile bleeding, a palpable thrill or an audible bruit, that whooshing sound over the injury site, a rapidly expanding hematoma, or clear signs of distal ischemia like absent pulses, coldness, pallor.
Okay, so hard signs E or R. What if you only have soft signs? Things like maybe diminished pulses, but they're still there, or a significant bony injury near a major artery, or
Yep.
maybe just a history of bleeding at the scene that stopped now.
Yeah, with only soft signs, you have a little more breathing room, but you still need to investigate further. The next step usually involves the Injured Extremity Index, or ABI in this context. You compare the systolic blood pressure at the ankle of the injured leg to the systolic pressure in an uninjured arm. If that ratio, the index, is low, typically less than 0.9, it strongly suggests a significant vascular injury even if the pulse feels okay.
And that triggers imaging.
That triggers definitive imaging, yeah. Usually a CT angiogram to see exactly what and where the injury is.
Okay, and one last really important complication that can follow either severe trauma or even successful treatment of ALI: compartment syndrome.
Ah, yes, the hidden danger. This is a surgical emergency. It happens when swelling occurs within a closed muscle compartment. Think of the lower leg muscles wrapped in tough fascia. It can happen after a severe crush injury, a fracture, or even after you restore blood flow to an ischemic limb that's reperfusion injury. The swelling increases the pressure inside that tight compartment.
And eventually the pressure gets so high.
It gets higher than the pressure pushing blood into the capillaries. So blood flow stops, and the muscle and nerve tissue inside start to die.
What's the key symptom to watch for?
The absolute hallmark is severe pain, particularly pain that is way out of proportion to the visible injury, and critically, pain that gets much worse with passive stretch of the muscles in that compartment. Like gently flexing the patient's foot upwards causes agony in their calf.
And how do you nail down the diagnosis and know when to intervene?
You confirm it by directly measuring the pressure inside the compartment with a special needle and manometer. The critical number isn't just the absolute pressure, but the difference between the patient's diastolic blood pressure and the compartment pressure, the delta pressure. If that difference is small, usually 30 millimillibrachii or less, it means there's not enough pressure gradient to perfuse the tissues. That's the trigger.
And the treatment.
Emergent fasciotomy. You have to surgically open up that tight fascial compartment to relieve the pressure immediately. Ideally, this needs to happen within about 6 hours of onset to prevent permanent muscle and nerve damage.
Wow, okay. We have definitely covered a lot of high-stakes ground today, from AAA rupture thresholds and the crucial type A versus type B dissection difference, to nailing down AFib stroke risk and that huge warning about AV nodal blockers in WPW.
Yeah, the real takeaway, I think, is the need for rapid, accurate assessment and then making these very specific, often counterintuitive decisions. Knowing when to pour in fluids, like maybe in an RV infarct, versus when fluids are the enemy, like in LV failure with pulmonary edema. Knowing when to block the AV node and when blocking it is absolutely forbidden, like in WPW with AFib.
Right.
Knowing when hard signs mean bypass the scanner and go straight to the OR for trauma or a suspected rupture, these aren't just academic points. They're the things that make a difference in these critical moments.
Absolutely. So a final thought for you, our listener, to chew on until next time. We mentioned how hyperthyroidism, a non-cardiac issue, can trigger AFib. You hear about things like cardiac sarcoidosis, another systemic inflammatory disease, sometimes presenting only with unexplained heart block or arrhythmias, especially in younger people.
Right. Forces you to think broader.
Exactly. So the question to ponder is, what other non-cardiac systemic diseases out there might show their first or most dangerous signs purely through these kinds of life-threatening cardiac or vascular emergencies? Something to mull over.